Okay, good evening, everybody. So what we've decided to talk about was the assessment opportunities in virtual care for the Royal College CBD framework. And just to start us off, we're going to build some context by recognizing programmatic assessment as one of the core components of CBD. And really tonight we wanted to emphasize some of those key elements of programmatic assessment that we're going to speak to. And to keep it in front of mind, there's been a significant shift in the assessment paradigm of assessment for learning as opposed to more summative. And the focus of that is around the observation of EPAs and their associated milestones. And so when we speak tonight and look at the various tools, there is some opportunity and perhaps an enhanced opportunity to capture more of the milestones and the intrinsic roles in some of the encounters. The assessment that we capture is for EPAs is across 4 stages of learning. And so the thinking there is the trajectory and the learning path for the trainee that it's building and enhancing. And there's a entrustment scale that is being used, and everybody's probably very familiar with it in terms of the O score. And that is slightly changed. I only wanted to mention it tonight because we did some change to the anchors of 4 and 5. There were some issues around verbiage. So just noting that that entrustment scale has changed. Also emphasizing, we've heard earlier tonight, the importance of quality narrative feedback. And so when we go into some case-based examples using the CBD forms, we'll emphasize how to capture more of that narrative. Very useful. Before we do that, let's take a look at some of the platforms. Everyone's familiar with the OTN platform, simulation, great opportunity there, and the Center for Simulation-Based Learning. They've done some terrific things. They actually have archived simulations available for everyone, both high fidelity and patients and simulated patients, and some of those are available to everyone. It's also possible to book a session for an hour where they can get through about 8 different simulations for one or a group. And that provides some opportunity to look at some of the other intrinsic roles, especially in those interprofessional scenarios. And they have used Zoom to capture those simulations, and quite successfully. The trainees responded that they felt it was actually quite real. So they're having great success there. The platform of Zoom is getting lots of traction, obviously for the video and audio options and things that we've heard, but assessment and being able to observe the verbal and nonverbal cues. Ted had already mentioned the recording functionality, which is terrific for post-review. So the recording can actually be shared again with an academic coach and with the trainee. Afterwards, the trainee themselves can review their own performance. For a self-reflection exercise, they can complete the self-reflection form and upload it into MedSys, or just use it simply for their own learning. Also for multi-source feedback, others can be invited to attend that Zoom session or share that link afterwards to contribute to that assessment. The mobile functionality or flexibility is worth mentioning with Zoom. Even in one context, you could consider triggering a form for completion on mobile while you're watching in a Zoom session to be unintrusive, but able to complete some of the forms using both platforms simultaneously. Zoom Healthcare is worth mentioning. It's FIPA compliant. It is being used by some providers across our hospital system, and you can just contact IT for that. Worth mentioning the best practices around Zoom privacy and security. And with regards to the previous discussion around texting and different ways of communicating, Microsoft Office Teams is now free in our Office 365 account. It offers a chat function and a collaborative space as well for video chat, and it works on mobile extremely well. There's another opportunity. The virtual medicine resources is assessments in MedSys. So we're going to go walk through, or Haroon's going to take us through the CBD forms 1 to 4 in a case-based approach, and with some tips and things to think about as you're striving to complete those forms. But there's also the self-reflection form I mentioned. It can be uploaded into the self-reflection documentation area in MedSys. There's an academic coach report. Some of the items are still being used and have been shortened down to 1. There's daily assessment forms. There's other sorts of tools to capture the assessment. The Royal College virtual teaching resources are useful as well. There's the link here and you can have it, it'll be shared afterwards. The CanMeds interactive site's worth mentioning. There's a number of different assessment tools there that are templated and can be customized as you look to address some of the particular areas of assessment that might not have been captured. And it's just another toolkit to dig into if you need to. So I'm going to turn it over to Haroon, who's going to take us through the CBD assessment forms with consideration of some cases and some examples of how to optimize the learner's experience.
All right, thanks, Lisa. Like Lisa said, I'm just going to be going over how we operationalize assessment and feedback within the CBD framework. And this is using the 4 forms that we've been using for our assessment and feedback. So the first form is the form 1, which is for EPAs and can be used for initial assessments. And those EPAs are untrustable professional activities. And in this particular case, we have a patient who's being seen in clinic virtually, the 70-year-old man. He's been referred from the emergency department with query heart failure. His vitals are stable. He is worsening swelling of the extremities, pedal edema, and orthopnea. So if you look through the domains for this particular EPA, you can see that a lot of the domains lend themselves very well to virtual care. Things such as communicating the diagnosis, demonstrating compassion for the patient can be done very well. Completing a patient admission, of course, that's not something you're able to do in a virtual care setting. But for instance, if the patient is decompensating or you can't assess them effectively in the virtual care setting, then you can use this as an opportunity, right? Oftentimes residents will think of this as a failure of the visit. But in this particular case, you can use it as an opportunity to see, like Joe had mentioned, their situational awareness, how they're able to transition that patient from a virtual setting to an in-person setting or emergency setting safely. So those are, these are opportunities for assessment. And I think that it can, these particular cases lend themselves very well, particularly if it's chronic management of patients or initial assessment of patients where the physical exam isn't critical. They lend themselves very well to Form 1 EPAs. There were some questions about the physical exam earlier. Currently, I mean, a lot of us is performing virtual care in the pandemic setting almost as like a substitute for care. But I think as virtual care moves forward, it'll be used as an adjunct tool, something that supplements and enhances our care for patients. And in that particular case, there are ways we can integrate physical exam, either if it's done in person when you see the patient initially, but also through the use of extenders. So if you're in a remote location, you can use stethoscopes that transmit heart sounds, lung sounds, and you can, an extender like a nurse or nurse practitioner can auscultate for you and you can actually hear the patient. So it's not like physical exam is completely gone, but of course there's certain aspects of it that can't be assessed completely. So that's our Form 1 and how it can be adapted towards virtual care. And I know as an academic coach, a lot of times we're very focused on these Form 1s and getting these EPAs, but offering the resident some degree of feedback at the end in terms of summative comment is also very helpful. Moving on to our Form 2. So a lot of the concerns that we've had from our procedural specialties is how do you assess procedural competencies and get the Form 2s done. And of course, there's no substitute for the in-person procedural component, but there are ways that we can get procedural competencies demonstrated in a virtual care setting. So for instance, the Form 2 here, we have a case ECMO assessment. So for instance, this could be done in a pre-op setting. This could even be done in the intensive care unit. For instance, if a resident has to talk to a patient's family, it's during the COVID time, the family can't come in, and they have to talk to them about the patient not doing well on the ventilator and having possibly to transition to a therapy like ECMO. In this case, the resident can get that consent virtually, via Zoom or any other video conferencing software that's HIPAA compliant. And you can see here that the consent part can be done very effectively can be assessed very effectively via virtual care. So, you can assess things such as how they allocate healthcare resources, how they're able to determine the patient's eligibility, how they're able to synthesize and interpret the clinical information, and how they're able to explain that to the patient and engage in a shared decision-making model with the patient's family. So, you may not be able to get all the necessary technical aspects of the procedural competencies, but you can still get the consent, which counts towards the Form 2 and procedural competencies, even in our procedural-based specialties. Moving on to our Form 3. So again, we're keeping the same case going. So for instance, if a resident in the ICU is talking to a family about consenting them for a treatment like ECMO, Form 3, the multi-source feedback, and this is both the Form 3 and Form 4 are things that we notice are not used as much in the assessment and feedback of residents. And these are very valuable tools. And if you use that same case of the ECMO, you can, for instance, if the resident is having this conversation with the patient's family, it can be recorded. And if it's recorded, stored in the cloud in a secure fashion. Of course, you need the consent of the family to agree to this. If it's recorded, you can then watch that after the interactions happened. And you can also use it as not just as an attending, but you can also use it as a form for multi-source and interdisciplinary feedback. So the video of the resident interacting with family can be shared with the patient's bedside nurse, maybe an RT, or even a social worker, so in an interdisciplinary format. And that you can allow these individuals to watch this recording on their own time and then provide feedback through any sorts of the collaborative tools we've discussed already. So this is an opportunity where virtual care can actually enhance feedback and allow for better interdisciplinary and multi-source feedback. So that's our Form 3. And Form 4 is our narrative observation. And again, I know as an academic coach, oftentimes I see the EPAs and the Form 1s and the EPAs and the initial assessments are done well, and they're almost like treated as these important milestones you need to achieve. But you don't necessarily get a complete holistic picture of the resident without some degree of narrative observation and feedback from the resident's supervisors. And Form 4 really allows for that. It allows you to really get that holistic picture of how the resident's performing. And it also the residents also find it very useful because this is the free text allows for very useful, actionable feedback. And I found myself in the virtual care setting that it's actually more efficient to use a Form 4 than I would in an in-person setting. Because in the in-person setting, if I'm making active notes while the resident is interacting with the patient, I can often look distracted. It can be seen as disrespectful by the patient. But in a virtual care setting, if I'm in a non-intrusive view, like the spectator view in Zoom Healthcare, or one of the blacked out screens in OTN, or doing it post hoc, I can in real time make notes about the resident and patient interaction and do this actually much more efficiently and effectively than I would in a physical setting where I wouldn't be able to do this in real time. So we particularly think the Form 3 and the Form 4, which we find are underutilized, can actually be used far more effectively in the virtual care setting. And that's a summary of the tools we have. Like I said, there are always limitations in the virtual care setting, but there are also great opportunities for enhanced assessment and feedback if used correctly.
you so much for walking us through a wonderful case example of how to use the tools, the digital tools that are available for capturing assessment in the Royal College programs at McMaster. So I think to sort of encapsulate what we've seen here so far today, we've heard a resident perspective talking a little bit about receiving or ways that could be useful to hear feedback. We've talked a little bit about best practices around providing feedback and learned that perhaps the structures stay in place. And then we've seen how to capture that feedback to make fulsome assessment across time, both in the moment, perhaps via narrative or the other forms or a field note, as well as longitudinally by collecting those short formative pieces of feedback so that we can make summative decisions about our residents and learners as we move on. So thank you so much from our expert panel. I'm going to pause and look at the chat box and open the floor if anyone has any questions about any of the topics or specifically for the assessment folk. If you want to type something into the chat box or unmute yourself, now is a great opportunity to ask your questions and have them answered by a really knowledgeable panel of presenters.